So thanks, Joseph, again, because you for helping us out again. I'm going to now move on with Maya. Maya, of course, we introduced earlier. Is going to give a talk with her daughter, which is great. In fact, I've never seen such an appropriate symbolism because she's going to talk about pediatric and adolescent gynecology. So Maya is so committed to this talk. She's actually brought her daughter with her just to kind of be in the whole role. It's fantastic. So Maya, thank you very much for doing that, and we're going to listen to your talk. Thank you.
Thank you so much for the invitation to speak today about when ultrasound is most useful in the pediatric and adolescent gynecology patient. Imaging in pediatric and adolescent gyne is really reliant on the use of ultrasound. This is really because this imaging modality is easily available and accessible, is not using ionized radiation, is easy to perform in young people. For example, for an MRI in a neonatal child that may require sedation. It's and it's highly reliable and has a high diagnostic yield in trained hands, in expert hands, but of course does not necessarily replace the importance of clinical judgment and assessment. In the majority of cases in pediatric and adolescent gynecology, we're probably going to use a transabdominal approach, and this will give us most of the answers that we're looking for. However, of course, we know that particularly for pelvic imaging, and particularly as young women become adolescents, it's most reliable to use transvaginal or transrectal imaging. Of course, you can also apply transperineal imaging. The challenge with transvaginal and transrectal imaging in this cohort of patients is that's not always acceptable in young people, but also sometimes it's not something that they would want us to do. And therefore, we have to get very, very good at our image acquisition of transabdominal imaging, ensuring a full bladder and using the correct probe for the size of our patient. And of course, probably having a slightly lower threshold for MRI if you're not able to get all the answers and patients continue to present with difficult symptoms. You probably would reserve CT scanning for staging of cancer. But I think before we move on and talk about ultrasound and when to use it and what we might see, we've got to think about what we might expect to see and what is normal in this cohort of patients. So on a transabdominal scan in a neonate, this is a typical appearance of the uterus. It may be slightly more enlarged due to maternal and placental hormones, and you may see a visible echogenic endometrial lining, again due to the influence of maternal gonadotrophins. You'll see the cervix slightly larger than the fundus, and again, the uterus and the appearances change over the course of the first year of life. And then you get this more typical premenarchal appearance of a tubular uterus with a non-visible endometrial stripe. And then the ratio to the cervix and uterine body starts to change. From the age of 9 onwards, from the premenarchal and postmenarchal period, you'll see the progressive widening of the uterus to a more typical pear-shaped appearance, and you'll probably start to see changes in the endometrium. And as menarche starts and periods begin, the typical cyclical changes we see within the endometrium. And this is the same for the ovaries. So in the neonate, you'll see the ovarian appearances as a slightly larger ovary with possibly some follicles, again, due to the influence of maternal gonadotrophins. The ovary will be slightly smaller in the premenarchal period with very small, less than 9 mm follicles. And from the age of 9 onwards, you'll start to see a more ovoid shape of the ovary with more follicles and potentially physiological changes in accordance to hormonal changes related to puberty and periods. So this is very neatly demonstrated in this study, which demonstrates the normative values and what you might expect to see. And you can see here again that the uterine volume is slightly larger in the neonate, reduces inside premenarchally, and then of course you'll start to see with the influence of gonadotrophins an increase in size of the uterus with a fairly normal distribution, probably related to the size of the young person and their pubertal status. And the same with the endometrial stripe, and the same with the ovarian volume. Very neatly, this study showed that the using where possible, they were able to compare transabdominal and transvaginal imaging, and you could see that actually the size of the uterus, the thickness of the endometrium, and the size of the ovaries was very comparable, and there was good concordance in terms of the measurements and the exact size of these very important organs. Now, what we don't know, and we don't have as much good quality data, is does this translate into diagnostic accuracy for pathology when using transabdominal imaging? But let's take a step back. When might we use ultrasound in the pediatric and adolescent gynae population? Well, let's look at the acute presentations of acute pelvic pain. And therefore, ultrasound's really, really valuable in looking at those with suspected torsions or cyst accidents and adnexal lesions, those with suspected outflow obstruction and hematoculpus, and potentially in adolescents who are sexually active, pelvic inflammatory disease. We mustn't forget that torsion is the fifth most common gynecological emergency, and about 30 to 40% of torsion happens in those under the age of 20. And even more interesting, really, is that it seems to be that in the pediatric and adolescent population, torsion in about 49% of cases doesn't really have to have an ovarian cyst. So it's just the ovary or the tube that is twisting. So this is clearly an important diagnosis. And there are ultrasound features that may lead you to be more suspicious of torsion. For example, an enlarged ovary, particularly when compared to the other side. You may see peripheral follicles, an ovary that is in an unusual position, free fluid, and the described whirlpool sign and changes in Doppler flow. Having said that, it's also possible to see very normal findings on ultrasound, and that's why this is very clearly a clinical diagnosis based on the clinical presentation of the patient. And if there are concerns about torsion, one would have a very low threshold to perform a diagnostic laparoscopy. And we would detort the ovary and leave it alone and not perform a nephrectomy unless there were any other concerns or the ovary, unfortunately, had already fallen off its pedicle. That's the acute situation, but what about in the chronic situation? Why might you otherwise perform an ultrasound scan? Well, in the prepubertal girl, you might see vaginal discharge or bleeding, or of course have abdominal pain or pelvic pain. You may have had a neonatally detected adnexal lesion that warrants follow-up in the neonatal and premenarchal period. Of course, you may find precocious puberty and signs of puberty before the age of 8, or delayed puberty, so over the age of 14, where a young person is not developing breast or hair growth as you would expect, or of course a palpable mass. In peri and postpubertally, of course, the most common indication is heavy or painful periods, and this is a very common reason that girls come to see us. About the data suggests that about 30% of girls will start to miss school because of their periods and stop participating in sport. And so this really is a very important quality of life issue. There may be endocrine manifestations that suspect an adnexal lesion, oligoamenorrhea, secondary amenorrhea, or of course primary amenorrhea, where you're not seeing periods from the age of 15, 16 onwards. Well, what might we see in any of these circumstances? Well, of course, it's going to vastly depend on what the reason you're doing the scan is and what the clinical presentation might be. But overall, the incidence of pathology in this age group in terms of gynecological pathology tends to be rare. Let's talk about each of those circumstances of when you might scan and what you might see. Adnexal masses in under 20-year-olds tend to be a relatively incidental finding, often because you're doing a scan for another reason. But of course, young people will present with symptoms that may lead you to do a scan that are often very similar to adult women, so abdominal pain, pressure symptoms, urinary frequency. But due to the nature of the type of adnexal lesions we see, you're also more commonly going to see endocrine abnormalities such as precocious puberty, menstrual irregularity, or virilization. So you may see virilization, for example, due to raised testosterone from a Sertoli Leydig cell tumor. And as we said before, many may present acutely. with abdominal pain and possible torsion. The commonest type of lesion you'll see in the adnexa in particularly post-menarche is a functional lesion, and often as an incidental finding or as a result of a scan due to pain or acute pain. And these are often self-limiting and resolve on their own. In terms of the other types of lesions you might see, you'll see here that the most common is a germ cell tumor, and such as mature teratoma or immature teratoma, followed by really quite quickly the sex-cord stromal tumors, such as the Sertoli-Leydig tumors or granulocyte cell tumors, and of course the epithelial tumors, and the others seem to be more rare. This is a table that very nicely summarizes the different type of histological subtypes of adnexal lesion you might see in a pediatric and adolescent patient and their typical imaging features. And however, having said all that, are there any ways, apart from learning these and pattern recognition and scanning lots, are there any other tools that we can use to help us better diagnose adnexal lesions in this cohort of patients? Well, you could consider tumor markers, and there are many depending on the type of cyst you may be worried about. So CA125 is typically raised in epithelial cell tumors, or for example, alpha fetoprotein in immature teratomas or yolk sac tumors. But in fact, they're only really positive, meaning abnormal, in about 54% of malignancies. So this isn't always useful. There are other features on ultrasound that may worry you more about malignancy, such as the presence of endocrine manifestations like precocious puberty, an age group between 1 to 8, a solid lesion, and a lesion greater than 5, 6, or 8 centimeters. But what about algorithms or diagnostic models that we can use? Well, this TOG article suggested the use of the IOTA simple rules, which we know has been extensively externally validated and performs very well. However, this wasn't validated for use in under 18-year-olds. There have been other models proposed in this cohort of patients. However, there's been very limited studies on this with small numbers and very little external validation studies. This is a very neat study that tried to looked at 318 surgically treated masses and found that actually RMI and CA125 did not perform as well, but potentially found the use of simple rules very useful in this cohort. And so this showed some promise for the IOTA simple rules. More recent studies have looked at whether we could use IOTA terminology in the neonatal lesion, and this group neatly demonstrated that we could. And in our own study, we were able to use the IOTA benign descriptors and simple rules, and they performed very well in characterizing adnexal lesions in our cohort of patients. This group from China did a very similar retrospective cohort study, mainly based on transabdominal imaging in under 17-year-olds, and actually found that the ORADS and IOTA two-step strategy worked very, very well and much higher than the pediatric risk of malignancy index score, which performed less well at characterizing adnexal lesions. So clearly there is hope for the IOTA models. And that is why the IOTA group have started this very large international prospective validation study called the Maya IOTA study to try and better improve diagnostics of adnexal lesions in this cohort of patients. So let's go back. So we've talked about acute presentations, chronic presentations, and adnexal lesions. What about disorders of puberty? Well, in precocious puberty, ultrasound may be very useful in those under 8 who are showing signs of early premature development to essentially assess the size and the shape of the uterus, any endometrial activity or thickening or changes there, and of course the ovarian volume and follicular activity and the presence of adnexal lesions such as a granulosa cell tumor, which may have led to these changes. It's also useful in delayed puberty, where you want to see, is there a uterus, are there ovaries, and what is their stage of development in terms of maturity based on, and we compare that to what we've talked about right at the beginning of the presentation of what we expect normative findings to be. Of course, and in included in delayed puberty is primary amenorrhea. And here again, you want to confirm the presence of the uterus, identify the Müllerian structures and potential differences in development. In particular, you'd be looking at outflow obstruction, which can present in this way. So key diagnosis you might make would be Müllerian agenesis or Mayer-Rokitansky-Kuster-Hauser syndrome, which is the absence of the uterus, the cervix, and the upper two-thirds of the vagina. An imperforate hymen, which may lead to this presentation of a hematocolpus or hematocolpus and hematometra, or a transverse vaginal septum. In MRKH, you might see these womb buds. These are often visualized on ultrasound, but also on MRI that may give cyclical pain. And you could see these womb buds here with normal ovaries. And so I wanted to briefly mention congenital uterine variations because this is a cohort of patients where you might detect these. We know overall the incidence of this can vary dependent on the population, anywhere from 5 to 13% to up to 23% if you're looking in a population of patients with recurrent pregnancy loss or infertility. But in fact, in our adolescent patients, you will pick some of these up related to menstrual disorders such as primary amenorrhea, where you might see obstructive anomalies, or of course progressive abdominal pain related to unicornuate uterus and an obstructed accessory horn, or of course MRKH. So do consider these diagnoses, and generally ultrasound is fantastic at assessment of this. You may reserve MRI, particularly in those with more complex anomalies that require further characterization. Another indication for scanning these young girls is really menstrual disorders, and particularly in severe dysmenorrhea not responsive to treatment, or where you're worried about very heavy bleeding and you're suspicious about pathology. But I should say that generally, when we're looking, particularly in the first couple of years after periods start, and we're trying to reassure girls and assess girls with heavy or painful periods, on the whole, ultrasound tends to be normal. And the reason for that is that most of the problems related to heavy and painful periods is related to anovulatory cycles, which are very common early on after menarche. And therefore, there is many studies that show that ultrasound doesn't necessarily change our management in those first few years when we're scanning for difficult periods, as about 70 to 75% will be normal. And so it is understandable that we could start treatment empirically without a scan and consider ultrasound for those who are very resistant to treatment. But of course, this will really depend on the clinical setting that you work in. What might we see in terms of pathology in adolescents who have terrible periods? Well, interestingly, this work has really been led by Katerina Exarchoustos, who's published fantastic papers and work on abnormal bleeding in adolescent population. And she's found that actually you could detect in those with quite severe disease, 13% will have deep pelvic endometriosis. She's also demonstrated findings of adenomyosis, and more recently, very interestingly, in a cohort of patients with quite severe dysmenorrhea in adolescents, you can detect mild features of endometriosis in about 40%. And when you do detect endo, it's more likely to be early and mild, which in fact is really reassuring, because what that means is we have a window of opportunity to detect earlier and instigate treatment, which is really, really important. So in really good hands, and where possible and where the patient consents to transvaginal ultrasound, and where they are really resistant to treatment, do consider these diagnoses in this cohort of patients. We mustn't forget, particularly in adolescents, that you can get sexual health and pregnancy-related issues, so such as pregnancy, ectopic pregnancy, PID, retained tissue, pregnancy tissue. And these are diagnoses that you can make, but always consider safeguarding and consent issues. And where you have concerns, escalate to the local safeguarding leads and pediatricians who you may be working with. Just a quick note on PCOS, if I may. Polycystic ovarian syndrome, as we know, is driven by insulin resistance and has quite strict criteria based on the presence of 2 out of 3 of oligoanovulation, clinical or biochemical signs of hyperandrogenism, and obviously polycystic ovarian morphology on ultrasound. And it is a diagnosis of exclusion because you have to exclude other etiologies such as congenital adrenal hyperplasia and Cushing's. The definition for what constitutes polycystic ovarian morphology has changed in recent years, and it's been amended to a follicle number of 20, measuring between 2 to 9 millimeters, or an ovarian volume of greater than 10 mils. On either ovary, and you have to make sure there's no corpus luteum, cysts, or dominant follicles present. So this is how we diagnose on ultrasound. But what is the problem in adolescence? Well, chronic anovulation is super common, irregular periods are common, and the number of ovulatory cycles actually in the first year after your period start is very low and still low even year 5 after your period start. And so irregular cycles and ovulation is normal in the beginning. And so this led Helena Teed to do some work and has done some wonderful publications. And she's the leader on the ESHRE paper and the international consensus to define more clearly what constitutes oligoanovulation in adolescents and what would define and enable us to diagnose clinical and biochemical hyperandrogenism in this age group. However, ultrasound is not used in the diagnosis of PCOS in those with a gynecological age of less than 8, meaning within the first 8 years after your first period. And the reason for that is that it's very normal to see lots of follicles within the ovary within this cohort of patients. And so it's not part of the diagnostic criteria, but oligoanovulation and clinical or biochemical hyperandrogenism is, and you have to have both of those to have the diagnosis. If not, you would be given a label of at risk of PCOS, and this would warrant further assessment down the line if your symptoms do not improve. And so, in summary, ultrasound is really the primary imaging modality in pediatric and adolescent gynecology. The vast majority of the scans we do are normal and reassuring, and really the incidence of pathology and the type of pathology we see may depend vastly depending on the indication and why we're scanning. There's really limited data on the incidence and detection of pathology using transabdominal imaging in this cohort of patients, and we really do need more data. If you do see a patient like this, please handle with care. It is often their first consultation with a gynecologist, possibly even a doctor, and we want them as much as possible to have a wonderful, fantastic experience and engage in their female health in the future. Thank you so much for your time. Hello.
Hi there, welcome back. So how's your pediatric patient you got there?
She's doing well. Hopefully she'll stay quiet. She's having supper.
Excellent. Okay, well, thanks for a great talk. Quite a big topic to give you there in that time because it's basically saying it's like adult ultrasound, but for little people, all in 20 minutes. But anyway, let's deal with a question from the audience, which relates, you will have seen, just in case people haven't, it's basically to is there a role, let's say, for transrectal ultrasound under anesthesia in the pediatric age group? I mean, so this is obviously something that's been talked about. What's the view?
Yeah, I think whenever we talk about this subject in webinars or at the conference, the kind of the way we image young people often comes up, and I think there's going to be a kind of a vast different answer on the whole. But from my perspective, I don't think there's really a need to do a transvaginal or transrectal ultrasound scan in a pre-pubertal girl. Post-puberty and when girls have menarche, I would say it's all about patient counseling. So if the young patient is willing or is sexually active, clearly it's appropriate to offer a transvaginal scan if they felt comfortable doing so. If they were not comfortable doing so or hadn't been sexually active, then you would proceed with a trans abdominal imaging. And you'd really reserve transrectal imaging, again, if they didn't want to have a transvaginal scan, you may offer it. But pre-pubertally, you'd only really be looking at transabdominal scan, in my opinion, which in most young girls will give you most of the information you require. I couldn't see an indication to do a more invasive scan. If you are worried about a complex anomaly, some other concerning adnexal lesion, of course, you may then proceed with MRI or CT scan. But I think that's exceptionally rare in young prepubertal girls.
Yes, I mean, I think it also, I suppose it depends on practice. I mean, it seems there are some places where people just seem to talk quite happily about doing transrectal scans, but I think I agree. I mean, it's an important time when you're seeing medical people, isn't it? And you want it to be a very at least traumatic as possible, I think makes sense. Now, I was actually going to ask you about PCOS because I mean, one sees so many people who are actually women who are told, "Oh, I've got polycystic ovaries." You know, you're seeing someone for the first time at 30 or whatever, and they've been told, and you say, well, "When were you told?" And it's like 14. And I'm very, very unusual to actually then see them and say and they're very confused because you scan them and say, "Well, you haven't got polycystic ovaries," and they've kind of had this label throughout their lives, and it's got to stop, hasn't it? I mean, basically.
Yeah, and so I think that's why the ESHRA guideline that's been published is really, really useful. So I would urge everybody to review that. Um, I think if the young person, adolescent, clearly falls into the diagnostic criteria, then that's fair enough, meaning they meet the definition of oligoannular ovulation or ultrasound and or signs, clinical or biochemical, of hyperandrogenism. Now, if they do not meet that criteria, then what you would say to the patient is that they are at risk. So we try and avoid the label now and try and give patients this kind of interim diagnosis of at risk and explaining that given time, their symptoms will either improve or the diagnosis will be much, much more clear. I hope that kind of makes sense to people, but we're trying to walk away from the label and trying to manage the symptoms in adolescents. But you can diagnose PCOS in adolescents in those that meet the criteria.
So you need to have a full workup and bloods and everything else, basically. You shouldn't be telling people on scan as a throwaway line, your ovaries look a bit polycystic because they look it up online. And of course, I mean, there's, you know, it's not a pretty story if you start searching around on PCOS online. Um, okay, the big issue, which I mean, we've talked about, and I know you've mentioned in your talk, but I just want to go back to it because I think it really matters, is about ovarian cysts and not and fertility sparing and just say about who should be looking after these women and operating and so on because um, you know still girls with hemorrhagic cysts and dermoids lose their ovaries for well I suspect no real reason to be perfectly honest. I just maybe just to emphasize that point, do you want to say something about that?
Yeah, I think that this is the whole idea of where the Maya study started because we I urge everybody to find out in their own unit what happens to young girls with cysts because traditionally, young girls who are admitted have been admitted by pediatricians or pediatric surgeons. And there is a lot of data, particularly in the UK, led by a pediatric surgeon called Sarah Brangard, that has demonstrated that a lot of, unfortunately, young girls who've had torsion, for example, have had oophorectomy. Or who've had cysts, such as a dermoid cyst, where the first operation that was done was an oophorectomy. And what that paper and that data has shown is that pediatric surgeons are wonderful and amazing and talented, but they are much more likely to perform open surgery, whereas gynecologists are more likely to perform laparoscopic surgery or minimally invasive, and that they're more likely to perform an oophorectomy in those with torsion and those with benign lesions, whereas we are more likely to detort an ovary and, of course, in the context of those with a cyst, perform a cystectomy and fertility sparing surgery.
Well, even if they need it, because a lot of these people don't need surgery at all. I think that's the thing, isn't it?
Well, absolutely. And so I guess it's this whole thing of trying to communicate across disciplines with pediatric radiologists, as well as pediatric surgeons and pediatricians to essentially share that number one, a lot of functional lesions will resolve spontaneously and do not need surgery, and you know, an interval scan is entirely reasonable in a young person who's well. And of course, in those who do need surgery, wherever possible, doing fertility sparing is critical, and where possible, operating together is even better, or at least collaborating and having an MDT and a plan. And there has been a consensus come out from the BRITSPAG, British Association of Paediatric and Adolescent Gynecology, and the British Association of Paediatric Surgeons, that suggests that more collaborative working is critical moving forward in the care of these young patients.
Thank you, because I think it's just a really important point to get across.